Thank you, Animesh, for inviting me. I'm here to talk about patient selection for proton beam therapy, and I divide the subject into locally advanced lung cancers, early lung cancers, and probably touch upon a little bit about recurrent re-radiation in lung cancers. So I think most of the challenges in thoracic radiation therapy have been highlighted by the previous speaker. But if you look at the eligibility criteria as per the major randomized trials, you need more younger patients, good performance status, less than 10% weight loss in the last 3 months, and a certain lung function. And if you look at the Swiss radiation oncology setting, about 1/3 of patients less than 60 years are not suitable if you go by these criteria. And if you see 50% of them actually are not suitable for concurrent chemoradiation, which is the standard of care between 60 to 70 years. And between 70 to 75 years, about 60% of patients are not suitable. So this is one of the key challenges. And I think we have seen one or a few patients actually dying of treatment-related toxicities in these settings. So if you don't select your patients well for concurrent chemoradiation, sometimes you risk losing them as well. This was highlighted by the previous speaker as well, that there are toxicities which are not just toxicities, but they actually determine the overall survival. So esophagitis, we know hard dose, volume of the PTV determine the overall survival, which is not very common in radiation oncology in other sites. The third challenge is that we do see subacute radiation pneumonitis, and more systemic therapies and immunotherapies are driving this toxicity. We know there are certain patients who are more vulnerable for this, but grade 3 pneumonitis seen about 5 to 10%, 2% have 1 to 2% have fatal pneumonitis as well. Cardiovascular toxicities have been highlighted by the previous speaker. It's not considered anymore irrelevant for lung cancers. People used to think that these toxicities happen after a significant period of time. Not really. We know that these toxicities happen much earlier. And we know who are the patients who are actually more vulnerable to develop cardiac toxicities: those with subcarinal nodes, those with multinodal station involvement, those with N3 nodal disease, especially with contralateral hilar disease. We know that these are the patients who are likely to develop more cardiac toxicities because we deliver significantly higher doses to the cardiac substructures. What is actually significant? Should we see the mean dose or cardiac substructure dose, which is the one which is important? We know from RTOG 0617 that there are certain subsites of heart which are more sensitive to radiation. And this is the base of the heart, which is supposedly the most radiosensitive, and this has been correlated with poor outcomes. We also know that with VMAT, we deliver about 2 to 5 gray to the entire cardiac blood pool and circulating lymphocytes. And we know that LD50 for lymphocytes is only about 2 gray. So there is a significant lymphopenia, and lymphopenia has been correlated with overall survival in multiple studies. So these are the challenges which I would say for thoracic radiation oncologists. And despite all of these toxicities and everything which I've mentioned, the outcomes are also clearly underwhelming. And we quote Pacific trial multiple times. We quote RTOG 0617. Let's not forget that the median overall survival is about 28 months in RTOG 0617. Pacific study showed 47.5 months. 2-year PFS is only 66%. And despite everything what we give to the patient, a lot of toxicity, and even some patients actually dying of toxicities, the loco-regional failure in the order of 40 to 50%. So clearly underwhelming outcomes, and we need to do much more. So therefore, in this background, I think proton beam therapy would be beneficial for certain cohort of patients. So why it is beneficial in certain cohort? It's because there is a physical advantage. We know, I think this is a radiation oncology audience majority, so we know that there is a physical advantage clearly, which translates to a dosimetric benefit. There is also a certain biological advantage in terms of, because the LET seems to be slightly higher in certain regions of the brach peak, the RBE is significantly higher. Maybe it could be higher by 10 to 40% range. But biological advantage is certainly there. There is also an immunological advantage because you are not irradiating the cardiac blood pool in entirety, and therefore there could be an immunological advantage in terms of reduction in lymphopenia. So these are the theoretical advantages. Let's actually see what the data suggests. There is dosimetric comparative studies, multiple studies, retrospective studies, single institution prospective studies, which are showing that there could be benefit in certain patients. But the real benefit, you have to, if you have to look at it, the devil lies in the details, because what technique are you using for protons? Whether are you using intensity modulated proton therapy? Are you using the modern image guidance? Are you able to keep your margins to the contemporary margins which we know of, which we usually use with conventional modern proton with modern photon techniques? Are we using various other techniques such as the newer algorithms, 4D robust optimization, how is the delivery, etc., etc.? So technical details do matter. So let us look at the literature based on these details and understand what the literature does show. There are now multiple phase 2 studies. These are prospective phase 2 studies across continents, mainly coming from North America and Japan. And these trials are showing that there is a promise for proton beam therapy for locally advanced lung cancers, but definitely that's not enough. There is a phase, it's a randomized trial, but it's not a conventional true blue randomized trial. It's a Bayesian adaptive randomized trial, which essentially means that patients who are feasible to receive this certain types of technique of treatment were randomized between proton and photon. And it's not a, as I said, true blue randomized trial. And despite all its limitation in terms of design, more pragmatic design, the primary endpoint of local regional failure and pneumonitis was actually not significantly different between proton and conventional radiation. And although the hard dose was significantly lower with proton beam therapy. Now, if you look at these curves, if you divide the patient cohort into first half and the later half, there was a clear-cut learning curve for patients who were treated with protons compared to patients who were treated with IMRT technique. There was no learning curve. And therefore, one would say that in first half of patients, the pneumonitis risk was 25%, whereas in the second half of patients, the pneumonitis risk was 0%. So there is a clear learning curve, which means that the trial was conducted too early, and therefore we do not see. And as I mentioned, it's a passive scattering, older technique of proton beam therapy. We now know that if you compare the modern proton beam therapy with the past, with the older technique of passive scattering proton therapy, the cardiac toxicities can be minimized with modern proton therapy. The pulmonary toxicities can be minimized with proton beam therapy. And this study actually showed, of course, as a retrospective study, showed that there is a trend towards improvement in even overall survival as well. Now, there is a National Cancer Database analysis. We know its limitations, but nevertheless, it showed that for stage 2 and stage 3 lung cancers, there seems to be a certain overall survival advantage when patients were treated with proton beam therapy compared to the IMRT techniques. Similarly, proton beam therapy can be used with immunotherapy. That has been shown. This is in the durvalumab era, 316 patients. Of course, this is all passive scattering proton therapy. Despite that, there seems to be acceptable toxicities with proton beam therapy and lesser unplanned hospitalization, lesser lymphopenia. And I've already mentioned lymphopenia could be a factor with respect to overall survival. This is another study which much larger cohort of patients. Patients were compared whether they have received durvalumab or not. Their patients were treated with proton beam therapy with concurrent chemoradiation. And you see that the patients who received durvalumab had a better overall survival as well as PFS compared to those who did not receive durvalumab, saying that with proton beam therapy and durvalumab, the toxicity is very limited, and it is feasible to do a combination, Pacific-like combination with proton beam therapy as well. So this is a randomized trial which is ongoing, RTOG 1308, proton versus photon, 70 gray radiation is being planned. This is although struggling to accrue patients, but I think this will answer that question. And there are now multiple studies which actually compare the cost effectiveness, because obviously proton therapy is an expensive treatment modality. And it seems that in at least in locally advanced lung cancers, in the North American setting, there seems to be some cost effectiveness benefit as well. Another study which actually showed very similar outcomes, when you individualize use of proton beam therapy, there seems to be an incremental cost effectiveness ratio benefit in patients who received individualized proton beam therapy. Of course, this is in the North American setting, not in the Indian setting, and there needs to be more literature on this particular issue. Now, let's look at early stage lung cancers, and multiple studies, again, dosimetric studies have shown that mean lung dose and the mean heart dose are significantly lower. Central tumors seem to derive maximal percentage benefit for both lung and heart DVH parameters. This is another National Cancer Database study, which actually showed that there is an overall survival benefit with proton beam therapy, with reduced toxicity, although the rib fractures were higher noted in proton beam therapy compared to conventional radiation therapy. Another study which actually reported patients of interstitial lung disease, you can see that the treatment-related ILD-specific toxicity was noted in about 16% in patients who received SBRT compared to protons, where it is only 3%. So some patients who have ILD could be actually be better treated with protons compared to conventional SBRT approaches. And this study was important because the dosimetric parameters V20 of 6.5% and mean lung dose of 4.5 gray were found to be important metrics associated with reduced mortality. There are similar studies for re-radiation. In the interest of time, I think I'll go very quickly that in patients who receive re-radiation, proton beam therapy could deliver higher doses to the tumor, lower doses to the normal structures, and the toxicities were well tolerated generally. So I would say that there are two important, and then of course there is some studies from the Proton Collaborative Group as well, which showed safety and efficacy of re-radiation with proton beam therapy. Now, the question is, how do we select patients? Do we select patients on dosimetry? Do we select patients on models? Models mean that patients who have a higher delta NTCP, normal tissue complication probability, higher than 10%, they are automatically, they should be treated with protons. Those who have very little normal tissue complication probability delta should not be treated with protons. And those who have somewhere intermediate level NTCP delta could be actually randomized between proton and photons. And this is what we have done for our high-risk prostate cancer patients. And we found that about 2/3 of our high-risk patients who require nodal radiation actually benefit with proton beam therapy. This is another modeling study which actually showed that patients who had pre-existing cardiac disease, patients who had disease with overlapping with or inferior to D7 vertebra, if their disease is extending below D7 vertebra, are likely to benefit more from proton beam therapy, because you can see the delta NTCP was significantly higher. And this is our experience so far. We've treated about 45 to 50 patients of lung cancers, and we saw that the 2-year overall survival is about 86%, progression-free survival about 75%, and the toxicity seemed to be very limited. This is, I would say, a 63-year-old gentleman who had severe T3N3 disease, 120 kgs. And this was what we achieved with conventional IMRT, 61%, V20 of 36%, quite a significantly different plan in a morbid patient. And this is what we achieved with protons. You see that reduction in the dose to heart was reduced from 30 gray to 7 gray, and the mean dose from 20 gray to 12 gray, and V20 36 to 22%. So significantly reducing the critical organ doses. And similarly, we've noted the same experience in N3 disease, patients with lower lobe primaries with lymph nodes, or patients with heavy nodal burden. These are the ones we see there's a big benefit of using protons. So to summarize my talk, in most instances, proton therapy would have a dosimetric advantage with IMRT, but we would not treat all these patients. But potential for reducing cardiovascular and pulmonary morbidity and mortality and for dose escalation is there. These are theoretical advantages. But my personal bias is that patients who would benefit the best with proton beam therapy are the ones with who have locally advanced cancers, lower lobe primaries, large primaries, significant mediastinal nodal disease, bulky nodes, N3 disease, and among early stage, poor lung function, patients with autoimmune disease, ILDs, central, ultracentral tumors, tumors close to heart, and of course, those recurrent tumors who require re-radiation. So these are, I would say, my go-to patients to go for proton beam therapy. Thank you very much.
Thank you, Dr. Chilikuri, for your nice presentation.